Welcome, everyone. Thank you for joining us today. I'm Hillary Pennington, and I oversee the webinar programming here at Sketchy. Today's session will focus on how program leaders can move from reactive remediation to a more structured, intentional approach to supporting residents, especially in fast-paced, high-stakes clinical environments. To help guide that discussion, I'm pleased to introduce our speakers today. First, we have Dr. Nikki Binz, Associate Professor of Emergency Medicine at the UNC School of Medicine and Associate Designated Institutional Officer for UNC Hospital's Office of Graduate Medical Education. Dr. Binz previously served as Emergency Medicine Residency Program Director at UNC for 10 years and has extensive experience supporting struggling residents and leading remediation efforts in residency training. She is a nationally recognized leader in graduate medical education and recipient of the 2026 ACGME Parker J Courage to Teach Award. Joining her is Dr. Ben Mueller, Chief Content Officer at Sketchy. Ben oversees content across both Sketchy's core learning platform and DDX by Sketchy, and has spent several years working at the intersection of clinical education and instructional design. His work focuses on translating complex medical concepts into practical, engaging learning experiences that reflect how clinicians actually think and make decisions in practice. We're really looking forward to hearing their insights today, but before we get started, just a few quick session details. The session is being recorded. We'll be able to share the recording as well as the slides after for anyone who wants to revisit the content or share it with colleagues. Please feel free to submit questions at any time using the Q&A feature. We've set aside at the end of the session for Q&A, where we'll address as many questions as we can. And just to set expectations and timing, we'll have about 45 minutes of presentation, followed by around 15 minutes for discussion. And with that, I will turn it over to Dr. Binz to get us started.
Excited to be here and talk to each of you today. As she mentioned, we're going to talk about how we can go into thinking more proactively about remediation with our residents and have intentional support for residents who are struggling, which are many of our residents at different points in their career. Residency is not a perfect line moving from intern to graduate. Everyone has a different path, and we need to support them where they are. I'm excited to talk to you about that today. Some goals and objectives for my discussion. We're going to talk about systems to identify these struggling learners, review some of the ACGME competencies and related requirements, describe best practices in GME remediation, scenarios about different real-life resident issues requiring remediation, and at least some insight into individualized learning plans for these struggling residents. So many of us are very aware and knowledgeable about what the expectations are for our trainees. Defined by the ACGME, we all have different milestones that fall under the 6 core areas of competency. In any one of these areas, residents can present with areas of deficiency. So we really have to be able to look at the whole scope of practice and at all of the different milestones. It's a lot to follow as a program director. They can present in different ways. Medical knowledge, for example, is an easy one to sometimes monitor if you have a mock board exam or other types of quizzes that your residents might do, whereas other things are a lot harder to identify. For example, professionalism. Some of these things are happening in everyday conversations and aren't always brought to our attention early. But educational leaders must set up systems to identify strugglers early and initiate proactive remediation. And that's what we're going to talk about today. So first off, one of the systems is feedback. Feedback is defined as an opportunity to bring attention to a gap between a recipient's current knowledge and skill and the level that they need to attain prior to graduation from residency, for example. Feedback really serves as a catalyst for their future learning, and ideally is coming from multiple sources, not just one person. And this is the first system that you really need to create within your program to identify your learners who are struggling. It is very complicated to promote a culture of feedback friendliness, but really important so that your program can operate efficiently and effectively and reach all of your learners. You need to make sure you're teaching feedback theory to both learners and teachers differentiate what feedback is versus assessment, encourage your trainees to seek out feedback. We all talk about growth mindset and how it's very different from how we focus in medical education historically. And we really need to help our learners reshape into goal-oriented learners rather than performance-oriented. We need to make sure we're directly observing our learners, which can be really tough in our busy, fast-paced clinical practices where the hospital and the clinics are all encouraging us to do more, see more patients, move through their hospital stay a lot quicker. We need to make sure we're having time with our trainees to see how they're doing. Invite our trainees to do self-assessment. We need to consider our emotional states. We need to develop relationships with our trainees, between faculty and trainees, so that we can have this positive culture that feedback is a good thing. And lastly, just make it a habit. Again, we're busy. We have lots of other tasks we have to pay attention to, but feedback is really, really important. The second system I want to bring attention to are your CCCs, or your Clinical Competency Committees. These are really designed to spot your struggling learners. We're going to talk about some of the ways that CCCs sometimes do that and give you some ideas for some best practices. So first off, right, the ACGME requires us to have a CCC, and these are some of the requirements around it. You have to have at least 3 faculty members who are named by the PD, and they're going to review every single trainee's performance at least twice a year and give them a number for each of their milestones for your specialty. The CCC is there to advise the PD. They're helping look at all of the data and come to the program director with advice on, hey, this resident deserves promotion, they need remediation, or maybe they're not making the cut and need dismissal. You need to make sure that they are really looking at everything as a whole and have their responsibilities written down so the whole team knows the high stakes that it comes with the CCC role. So how do you do this well? If that's a big ask, especially if you're a program that has more than a couple of trainees. We need to make sure that, again, back to our first system, that you have a good feedback system and evaluation system in place. And ideally, that's going to include faculty, peers, nurses, staff, anyone else that your trainees are interacting with on a regular basis. Write up what your CCC does. Make it transparent so that the residents know what data is being looked at, where is feedback coming from, so that everyone knows what's on the table to be reviewed. Set up an adequate meeting time, which seems easy, but again, if you have multiple trainees, this is going to take a lot of time, which can be really difficult to find in physician schedules. You need at least 5 minutes, maybe 10 minutes per trainee, and that can only happen if you are well prepared. If you're not well prepared before the meeting, it's going to take a lot longer per trainee, and you are going to lose the attention span of the faculty who are there. Some programs who are rather large or need more time to talk oftentimes will divide up their trainees and have multiple meetings where they might talk about interns at one meeting and then a future date with senior residents, for example. Ideally, have some kind of structured data tool, a dashboard, some kind of electronic evaluation system that really enables you to pull everything together and look at a big picture and identify patterns. Many of us use some kind of an electronic residency system, and that helps with some of these things, but there are a lot of other areas that data is coming from that you might want to create your own personalized dashboard for your program. And then lastly, you need to work on faculty development, on how a CCC needs to run, teach them what the milestones really mean, how to be aware of bias, and how to be fair for your trainees. Some other just real practical tips. Really, if you can have someone on your team help prepare things as much as possible ahead of the meeting can be really, really helpful. Program coordinators are often excellent at this and can help collate information and present it to faculty so that things can be more efficient during the meeting. Making sure everyone understands what the milestones mean. And even if it's just simply, an intern is not going to be a 5 out of 5 on all of the milestones. It's just not how they're written, which again, very much contradicts what a lot of our historical medical training has been around goals. Provide timely feedback after this meeting. For example, you've just had this meeting and you've spent 4 or 5 hours talking about all of your trainees. Use that as a great chance to, again, resend constructive feedback to your trainees. And lastly, use it as a continuous improvement process. See how it's working, try to fine tune things that aren't quite working, and incorporate future ideas into your CCC. This, for example, is one of the things that our program started that really helped us have a good bird's eye view of every single trainee in a one page. So my residents, many of the things that we tracked were, for example, their conference attendance, which is a requirement of our RRC. We look at sepsis. That's one of our metrics that we follow, whether they're using our sepsis bundle and getting antibiotics administered quickly. We look at their in-training exams, which they take each year, and follow how they're progressing compared to their peers nationally. And then we look at several metrics related to their clinical patient care. In emergency medicine, one of the most important is how many patients per hour are you seeing, and can compare them to their peers. And this is a great one page to just see how a resident is, see where some of their weaknesses are, see where their strengths are, and for the residents to also view this and know where they are, as opposed to having to find this in multiple different places in our different programs. Then behind this for our CCC, we'll have evaluations, self-evaluations, and more detailed information. This is a great thing to bring for everyone to look at quickly. And then after our CCC, we would send an email to each trainee about what we talked about in the meeting. We would give them an overview of how they're doing on their milestones, talk about what the group mentioned were their strengths, as well as areas to focus on and improve over the next 6 months until the next CCC meeting. Residents really appreciate this, that way they know what's going on behind closed doors and it's not some top secret talking behind their back, but we really care about them and are trying to identify those gaps and help them close those gaps to reach their full potential. So then moving into remediation, which might be brought up during your CCC, you might identify a resident who has a significant area that needs some improvement. And it's really tough to do remediation. A lot of people kind of hear that word and start to cringe because it is really challenging for a lot of different reasons. First off, just identifying the problem, right? It can be hard because there's so many people involved in the education of a trainee. Everyone's in different places, they work at different sites. So you need to make sure you're getting information from all of those areas to get a comprehensive view of how your trainee is doing. And you need documentation, right? There's got to be more than just the side conversation in the hallway. And hopefully you're getting comprehensive feedback and evaluations in. And then you have to get the resident to actually buy in, right? They have to be open and not defensive about, hey, we're going to help you. You have a gap here. Let's talk about it. Many times they're resisting that at first. So then we have, again, deficiencies in our evaluations. Direct observation is tough. It is very timely, time consuming for faculty to spend a lot of time directly with trainees in the presence of patients. You have to be able to discuss with their learner openly about their deficiencies. We need to make sure we're tracking attendance, evaluations. One of the most time-consuming thing of remediation is that they really need to be individualized. No trainee is exactly the same. There are definitely patterns we've seen if you've been a program director or in GME long enough, but each case is a little bit different. You need to have measures of progress for remediation. So you might know where you are, but then how do you track to where you want them to be? And can you follow that along in real time? And that takes a lot of administrative tasks and a lot of extra time of faculty to do this. And then lastly, the program effects that it might have from remediation. For example, you may have a trainee that you're concerned about performing at an appropriate level and you have to switch their rotation or pull them out of clinical setting, which then is going to potentially change the environment of those around them and maybe even increase work burden on others, which we don't want to do, but we also want to keep our patients safe. And so we have to think about all these things. Sometimes legal gets involved. They can be very, very complicated. But what is most notable as a challenge of remediation is just time. It takes a lot of time to do this. And actually, one study looked it up and it said that faculty spend an average of almost 20 hours of additional time with a struggling learner just to explain and implement remediation. This is not even including the time spent planning and reviewing or on the back end assessing to see how they have progressed through this remediation. And so it takes a lot of extra time. I highly recommend that you know your sponsoring institution's GME policies around remediation. Every place is a little bit different, uses different language, and so be aware of the resources and policies at your own institution. But globally, in general, GME has different levels of remediation. Starting at the top, we have informal remediation. And this falls under every single program director's responsibility to initiate and follow and end wherever they think appropriate. Um, Ideally, you're using some kind of standardized documentation, which we'll talk about in a minute, with some kind of timeline of progress and expectations. And then from there, you can escalate. If a resident is not being remediated appropriately, you might move on to a more formal remediation. And this is when you would loop in the GME office and your DIO. Our institution calls it a letter of deficiency, and the DIO and our legal team and the PD work together to create a more formal letter of deficiency that's similar to the informal stage of hey, these are the areas where you have gaps and deficiencies, and these are the expectations we ask that you continue to follow through on, whether they're extra tasks or meeting deadlines, and then an end date for the letter of deficiency. Should a resident still not continue to progress, then they might move on from there to either probation or termination, which would also include non-renewal of a trainee. Luckily, that rarely happens, especially the earlier we start with remediation. It gives us more time to work with the trainee to address their gaps. So encouraging this as early in training as possible. So the last system is to create a really strong informal remediation program for your residency or fellowship program. Some of the key things that it needs to be. It needs to be a transparent process. They need to know what to expect long before you're starting this process. So letting your interns know day one, hey, this is what our program does to support trainees who have areas of improvement and what we're going to do to support you. You need to make sure that it is described as not punitive. We're here to help you. We care about you. We want you to reach your goals and beyond. And so we're going to do everything we can in our power to support you. These remediation plans need to be very specific. They need to target behaviors, not personalities. Ideally, the trainee is working with you to create their own individualized plan. They know what works for them, what doesn't work for them to an extent, and sometimes they need our advice to say, hey, that's just not working if that's what you've been doing so far. But they may have some ideas of resources that they already use or know things that don't work for them. Standardize the documentation. It'll make it easier for yourself every time. There's no reason to recreate the wheel. You're going to do this more than once if you are in program leadership for more than a couple of years. Figure out ways to increase the amount of feedback that you and the trainee are getting about their performance. That will help you decide how they're progressing. And so figuring out if there's more evaluation forms or feedback forms or informal emails. Frequently, I would have my program director, my program coordinator help me and reach out to faculty on an almost daily basis of, hey, how did so-and-so do today? Can you please give us some comments anonymously? Hopefully, they're also giving verbal feedback to the trainees, which is really important too. And then define what success looks like and what the next steps might be if should they get there or not get there. And really, if you're at all thinking about should I start a remediation plan with this resident, I really encourage you to just start it. Even if you think it's going to be short, it is there to help them, and so there's no reason to wait and hold back. This is an example of our template that we use at UNC for all of our informal remediation plans. And it just talks about how, hey, we really value you. You're a little behind. We're going to help you get to where you need to be. This is supportive and encouraging, not punitive. And the whole faculty agree on this, and we're going to work together. We then come up with the milestones that are the areas of deficiency so that they can understand, hey, these are the things that the RC is expecting of our trainees, and you're a little behind. And then come up with your implementation plan. I highly recommend that it always includes regular meetings between the trainee and either the program director or an APD or maybe another core faculty or mentor that they work really well with. Again, this takes a lot of time. And so the bigger your program is, the more people hopefully can help you because one PD alone cannot take on the remediation of every resident in your program. Talk about ideas for how you can resolve these deficiencies. Is this going to be a study plan? Is this going to be some coaching? Is this going to be doing more questions, doing more problems, more one-on-one teaching sessions with faculty? The list can go on and is going to be very dependent on each case. And then explain, hey, we're going to come back in a couple of months and see how you did. Some remediation plans are a month, sometimes they're 3 months, sometimes they're 6 months. Whatever you think works in this scenario, I tried to keep mine mostly standard to 3 months because shorter than that is hard to change habits. And oftentimes would extend most remediation plans by another 3 months just to make sure things were really set in place and the resident was progressing as planned. And then here it explains that if you're not meeting these requirements, if you're not doing what we're asking of you, or you're not progressing like you should, this could get escalated to the next level of formal remediation, which at our institution is called a letter of deficiency. There's also a way to be even more proactive, right? And so we have trainees that come to us with a lot of data and statistics already. They come with an application of some sort, right? So whether it's through ERAS, right, or you have how they did on all of their step scores, we have a lot of information of how they've performed thus far. And so you might recognize that in their application that they have an area that might be an issue for remediation as a trainee. For example, if they, are scoring in the bottom 10% on step scores or had a failure, you might already know, hey, this person is going to have a little bit of a harder time with standardized tests likely. And so my specialty requires them to take the boards. And so I'm going to work proactively with them to make sure they can pass their boards when they're finishing our program. And so encouraging residents to start remediation from day one, having a conversation with them of, hey, these are some things we noticed in your application. Can we go ahead and just start from day one supporting you and giving you some extra resources and some extra time so that you can be successful in your time here? And then we also let residents self-identify. Maybe they are just, worried about something new in their life, right? They've moved across country, they don't have a support system, maybe their family life has changed, and they just want someone to kind of be looking over their shoulder and encouraging them and holding them accountable. And so this really takes away that punitive shame feeling that trainees have around remediation, and that they're choosing to do this so that we can help them become the best physician that they can be. And so we have an intake with them and talk about what they're worried about, where they have succeeded or where they have failed in the past, and create that individualized plan from day one before we're getting any feedback about any concerns or deficiencies. So a couple of cases to show some examples, all right? So during the next couple of cases, I want you to think about 3 questions. First, what competency categories does this learner's deficiency fall into? And usually there's more than one area. What steps would you take to correct them? And lastly, what would be your marker of success in remediation? Because oftentimes that's the hardest thing, is the vague thing. When we feel like this resident has, performed well enough to come off remediation. So case number 1, the inevitable. Resident physician A is a second-year resident who performed in the top of her class as a medical student during her AI and intern regarding her medical knowledge on shift and on the yearly mock board exam. Sounds like everything's going great. And then as a second year, faculty have noticed that her knowledge on shift is now a little behind her peers. She scored lower in the 10th percentile nationally on her mock board exam, and some of her charts are frequently not completed in a timely manner. So we've seen a change, we've seen a shift. She seemed to be doing well, now is behind in medical knowledge and hasn't been progressing as much as her peers and have the charting issue. So the areas of deficiency with this resident fall into several categories, which is the most common. First off, clearly medical knowledge. Her mock board exam results are in the bottom 10th percentile. Then there's some professionalism concerns around the chart completion, having to do with accountability specifically. And the on-time chart completion also relates to interpersonal communication skills, right? This is how we talk to one another in the healthcare setting. This is how physicians know what is going on, what consultants have said, what happened in the ER before admission. And then lastly, another area around professionalism is there something else going on with this resident? there's been a significant change in how she was as an intern to now how she's being as a second year. Is she burnt out? Is she not taking as good a care of herself, right? A lot more responsibilities come with being a second year. Has there been a shift at home? So then what steps would you take to correct these deficiencies? And so, as I mentioned with our standard process, having meetings about every 2 to 3 weeks to just talk about how things are going so that you can get continual feedback from the trainee on what's working, what's not working, continue to talk through some of the more soft skills that it comes with being a physician. Write down specific goals. This one has to do with medical knowledge. So explain exactly what this resident has agreed to do. So for example, this resident has agreed, I really like doing questions. That's what's going to help me pass my boards. So I'm going to do 100 questions per week, and they can talk about the different resources they like to use. You might have additional online assignments. There are a lot of great resources out there. You don't need to reinvent the wheel. Use your specialties, books or online question banks, to do more online assignments, and maybe they're doing an extra assignment a week. Many of our residents like to listen to podcasts. My trainees would do some decent commuting, and so it's an easy way to be studying while they were in the car and listen to videos or podcasts while they were going to shifts. Um, Make sure that someone is reviewing this on a regular basis, that they're actually doing them. You don't want to wait till the end of 3 months and realize they never did any of them. So having a program coordinator or a PD, make sure they're looking at dashboards, and giving them feedback or reminders if they need it. Any remediation plan, I always encourage some kind of a mental health reach out, right? Because residency is tough. And as soon as you're tired or burnt out or have other issues going on, it can be really hard to perform at work. We cannot require mental health, but we can always recommend it. And so, whatever options you have at your institution, make sure they're aware of them. And then set an expectation with this trainee that your charts are going to be done every single day at the end of shift before you can go home. And you're going to have to show your faculty member that your inbox is empty, before you can go home, to make sure that these are done. And then at the end, this trainee can do a mock ITE to see how their score has done. So is doing all of these things really helping get them back on the right plan for their medical knowledge so that they can continue to progress and pass their boards at the end. So as you can see, 3 months is probably not going to get her from 10th percentile to 70th percentile, and why many of these remediation plans need to be continued, but hopefully creating good habits up front. And so the markers of successful remediation for this trainee would be, you can set a goal of, for example, at least 40th percentile on your mock board exam compared to other PGY2s, and a greater than 90% timely chart completion. There's always those couple of charts that get lost, so expecting 100% might be a little much, but set a reasonable expectation that someone can attain. And this trainee was very involved in creating this plan, and making sure it is doable for them. Case number 2, this is resident physician B, or the unavoidable. This is an intern in emergency medicine. He's early in his training, and faculty have noticed that he spends a really long time in the room taking history and physicals, even up to an hour, which is, as much as we would like to do that sometimes, is not okay in the emergency department. He's also really struggling with developing that appropriate worst is first kind of emergency medicine differential, and what is required of ER docs to think in their workup and treatment plans. Everyone really likes him. He works really hard. He is a really good, empathetic, and kind doctor, but he's really struggling in the ER. He cannot task switch. He seems to be less aware of what's going on in the ER. For example, if an ambulance is coming by right in front of his desk with a new patient, he's buried in his computer and is not aware of a new acute patient showing up, and has struggled with taking care of more than 1 or 2 patients at a time. He has gotten feedback from faculty on shift and in written evaluations, so he is aware of this. And reviewing at the CCC with PD and APD is just, he hasn't really shown any significant improvement with this verbal feedback. So the CCC recommends for him to move on to a remediation plan. And this one is one of the common types of remediation, encompassing a lot of the different areas of our training. And so first off, many of these things are falling under patient care, right? Being able to do a focused history and physical. These are related specifically to emergency medicine, as this is the case, and what I am most comfortable talking about. Being able to create a differential, medical knowledge, just knowing the common clinical settings in the ED. And then it really encompasses all of the different areas, systems-based practice on acuity of patients, practice-based learning, interpersonal and communication skills, and professionalism. So this is one of those that you're like, oh my gosh, where am I going to even start with this training? There's a lot going on. And so you really need to break it down to each of the milestones and deficiencies and come up with a plan for those. So what would be the steps? Again, we're going to have regular meetings. I need to be with this trainee on a regular basis to make sure that he understands where he is so that I can understand more of what he's thinking, where he's still struggling, so we can support him and help get him to his goals. With this trainee, we created a personalized ED schedule. We took him off of the regular ER schedule because as we were approaching second year with this trainee, there's going to be a lot more patient responsibility on the resident. He just wasn't at a place that could handle that quite yet. And so we made him an extra resident, and so that we wouldn't have to rely on him seeing too many patients per hour that we knew would just set him up for failure, and obviously not be ideal for our patients either. So he was on a specialized schedule where he was only working with our core education leaders in the department so that we could really see how he was doing and dedicate that extra time. We weren't letting him put in orders until he talked to an attending, which is atypical of a rising PGY2. We made sure every faculty could do a feedback form on every single shift, trying to get as much data back to us to see how he was doing. Doing at least one standardized direct observation tool on every shift work so that you can really see what he's doing in the room so we can help coach him on how to get out of the room quicker, for example. We worked with him to shadow some of the great chief residents so that he could just see how their behaviors were different, how they were able to work more efficiently in the ED. And then he was supposed to look over his notes with the faculty to make sure he was talking about how emergency physicians are thinking through the worst case scenario, right? This chest pain, I don't think it's an MI. I don't think it's a PE because of these things. And then utilizing teach back to make sure he really understood the plan and what was the crux of each case. So markers of successful remediation for this trainee would be improved feedback from the faculty, that he would be trusted to do the typical PGY2 responsibilities, which would be staffing, being able to see a patient, write in orders, and then staffing, and improve feedback from his senior peers during these observation shifts, or possibly even during transitions of care and sign up. So in this case, despite the trainees' best efforts and us as program leaders, the remediation failed. But in the end, it's not a failure. It was really a successful transition. Through many of these biweekly meetings, we were able to discuss what his goals are, what he loved about medicine, and just recognize, you know what, you're a great doctor, but just emergency medicine is not going to be the best fit for you. It doesn't allow you to do what you want to do and what you're good at. So let's find another specialty that works for you. And so PDs really are the gatekeeper, to throw it back to the Ghostbusters. And we really are responsible for the future of patient care in our specialty. And this is a lot of responsibility and a lot of weight. But don't see it as a failure in these kinds of cases. It's, the earlier you can identify this and help a trainee get to where they're going to shine and be happy and have a long, successful career, then that's a job well done by a program director. And it's going to happen. The last case is the inescapable. And so resident physician C is a PGY2 who is handling consults for the first time. Many times it's a second year who gets that consult pager. And when they were an intern, they were doing good. They had, appropriate knowledge and workups, took good care of their patients and worked well with the team. Everyone recognized them as a great trainee. But now early in the second year, you're hearing some concerns about his communication, specifically with handoffs to his peers and with consults. Others have complained that at sign out, he's left out a lot of important data that then the overnight resident maybe had to pick up on or clean up on some of his mistakes. And other departments have sent a few emails talking about unprofessional communication or significant delays in consults and calling back consults or calling back with plans and recommendations. He has received some feedback already, but have not noticed any changes in his performance yet. So what would we do for this case? Well, again, you're going to meet with them regularly, and then really clarify what the expectations are. Really explain what a consulting physician needs to be able to do, and really ask, like, why aren't these things happening? Is it that they're overwhelmed with other tasks that they should already have delegated to someone else? Is it that they are just uncertain and that's why they're delaying? They're afraid to ask for help. Really understand the why in this case. You might practice some mock cases, right? So you can do some practice in the office, consultant calls, right? Say, hey, for example, so-and-so pages you with questions about this, and practice some communication scripts. Talk about IPAS, for example, with sign out and handoffs. Help them create a checklist for when they're on a consult call. Make sure you're getting a lot more feedback again from faculty and peers, especially those peers is so important for handoffs because generally trainees are signing out to each other. Consider if you have a great chief to do some peer coaching to really, stand next to them while they're answering the calls and calling back, and they can coach them, prepare them for each conversation and debrief. Try to get some direct observation to see how they're doing it, and then track consult times, which can sometimes be harder than stated, to make sure they are getting back to teams who need answers quickly. Markers for successful remediation here would be, again, improved feedback, entrustable to be a PGY2 consulting resident, and maybe their consult times. So those are just three kind of common cases that I see in GME. Every single remediation case is a little bit different and just takes a lot of time to sit down, but it's really important to support our trainees. And the most common missteps by PDs are just delayed identification and remediation initiation. So make sure you have the systems to identify early, and if you're thinking about it, just start the remediation so that you can support. There are a lot of great resources out there. The ACGME has a great comprehensive remediation toolkit. I highly recommend you check it out. And again, it's really about turning observations into targeted remediation. So target the behaviors that are not where they need to be and help close the gap on these deficiencies to get them to be competent physicians and successfully finish your training program or potentially transition to another option. All of that is successful as long as you're supporting the trainee to help them become the best physician, or best whatever they need to be in this circumstance. And so competency gaps rarely announce themselves, but patterns do. So just create the systems to identify them early and respond to them early. And that starts from day one. Normalize remediation, destigmatize help-seeking behaviors that many folks in medicine are afraid to reach out and ask for help, model vulnerability, and really create transparent processes that trainees feel comfortable and supported in. And so again, early intervention and prevention, collect more data early, identify the problems early, and I promise that you will have better outcomes if you really have these systems in place for early identification and early initiation of remediation support of your trainees. And thank you. With that, I'll pass that over to Ben.
Yeah, thank you so much, Nikki. That was an awesome overview, and I love particularly the cases because I feel like I saw some of those people myself in residency. So I'm going to sort of pull at some of the threads that you talked about and give some context about how we're thinking about addressing those issues with DDX, which is our AI-enabled case simulation platform. So just a little context on that. DDX, like I said, it's clinician built and AI enabled, and we think both of those aspects are really important. Clinician built, a human being touches every single thing we do here. A physician clinician reviews all of our cases and sort of thinks about not just is this medically accurate or sort of clinically correct, but what is the right way to teach residents. So we have about 130 odd cases sort of spanning the spectrum, excuse me, of clinical reasoning, communications, and clinical skills, which we'll talk about. Those have rubric-based assessments at the end, so you as the faculty can understand the resident's performance in this really sort of detailed and helpful way. And like I said, built with the assistance of a large number of clinical faculty. And then for the resident, they get this experience that lets them practice in a safe way. And I think a lot of what you talked about was those opportunities for practice and I think by the time you get to residency, you've done 5,000 questions for step one and 1,000 questions for step two, and you're just kind of a multiple choice question machine. And I think that's oftentimes a comfortable place to sort of feel like you're making progress. But we think that there's potentially more benefit in doing something where the knowledge really has to come out of you rather than relying on your question answering skills. And then we build these sort of to help them progress, to give them actionable feedback based on their specific behaviors. And then we've got some of our awesome partners pictured there sort of across the UME and GME spectrum. So how do we think about clinical readiness, particularly for this environment? So first is, like I said, we think that being in this experience where you really have to talk to a patient, you really have to talk to your attending, you go through these interactions just as you would in real life, we think is extremely important. The breadth and the depth here, I think, are unlocked by AI, where we have this very large case library that allows residents to get reps and sort of practice, whether it's across a variety of diagnoses or presentations or sort of down one train, right? Chest pain can be a lot of things. ACS can come in looking a lot of different ways. And so helping them practice those different parameters we think is really important. And then if there's something missing that you think is really important for your resident or your cohort to practice, we have ways for you to easily add additional cases to the library. Like I said, we have that rubric-based feedback that lets you track your residents' performance over time and sort of localize the lesion, as it were. And I think that's something that you talked about a lot with your specific cases is what is the actual problem here? Where is the deficiency? And so we think that DDX is one great way to help you do that. And then, you sort of hammered this point, and we think it's really important too. Early, early, early. The earlier you can identify these problems, the more your intervention can help, the easier it is to have a successful outcome. And so we think that this is a really great way, again, to sort of uncover a resident's thinking, which can be really hard to do sort of in real time in a busy hospital setting. So this is an awesome option for doing that. The other the other piece of time, so in addition to early intervention, you mentioned the time burden on faculty for doing this. And so, one goal here is to alleviate that burden to some extent. There's no substitute for sitting down with your resident and understanding what they're going through, but this allows faculty a way to sort of take a lot of the busy work off their plate. So, case building, evaluation, scoring, sort of tracking all of that. This handles that for them so that they can focus on sort of understanding the resident's specific problem and communicating with them and making them feel supported in that way that you were talking about that's so incredibly important. So using DDX, we think, really unlocks a lot of faculty time. And so just sort of the flow here. So, starting DDX early localizes those issues, identifies those deficiencies, and allows you to start intervening on them. We give you pretty specific insights on where the problems are. The same feedback that the resident can see about their performance, you can also review for them. And then we track that over time and sort of as you remediate them both through DDX and through practice, you can see their improvement or where they're still struggling to improve and where sort of maybe more intervention is warranted. And so with that, I am going to jump in and show a quick demo here of DDX. So just a quick overview of our case library before I jump into a specific case. Like I said, about 130 cases here. Just to call out a couple things. One is communications cases. And like a lot of stuff in DDX, we are trying to cover a pretty good spectrum of what communication means here. So that might be delivering bad news to a patient or talking with a patient about their desire to leave AMA. But it might also mean a patient handoff or sort of the interprofessional communication that's also really crucial and where we often see breakdowns in residents, handoffs and consults and things like that. We have a bunch of clinical skills cases, so just sort of how can we dive into those technical skills that are so important? Reading EKGs, interpreting chest X-rays. We have some POCUS cases, so not necessarily clinical reasoning as such, but a lot of the skills that are really important to residents. And then, of course, clinical reasoning is kind of our bread and butter, and so I'll jump into one of those cases here just to give you a sense of how DDX works. And so in honor of Nikki, I'm going to do a more ED flavored one. There's also kind of the second half of this case that's after this patient is admitted and maybe has more of an IM flavor. But we'll go through this one and kind of talk about how the platform works. And so just as an overview, this is the faculty view. You can see the diagnosis and all the steps of the case and kind of do a quick review before you assign it to your resident to make sure that this is the right case for them. But what they see when they start the case is typically some chart review or some sort of review of prior notes. Again, just like they would do before they went to see a patient, quick look through the chart to see what's going on with them. Here's the urgent care note from before they presented to the ED. Great. And then I think this is really important. I think you were talking about this with one of your residents, the ability to sort of make that differential. And, in this case in particular, think about what's the emergency differential here, right? Are you including the high risk sort of can't miss concerning things on this list? And so we'll just throw a couple of those on here just for fun. But we really want the resident to sort of demonstrate their thinking. And again, I think this is something that can be quite difficult to ascertain in real time, in real life, where if you stop them every 30 seconds to say, what are you thinking? What are you thinking? The whole interaction becomes impossible. But here we can sort of surface what they're thinking about as they're going through the case. So they make their differential at the beginning here, and then it lives on the right side so that they can keep updating it as they go through the case. They then have the opportunity to talk to the patient. Again, you mentioned residents sort of go from med school where the goal is to spend as much time with the patient as possible to the real world where the goal is to be a little more focused and efficient. And so we model that with these conversation limits, but also with some key findings behind the scenes. So you can see, are they spending a ton of time to get not that much information out, or are they being more focused and efficient here? We won't go through these first couple because I think they're sort of self-explanatory, but we'll do a quick exam, again, sort of proctored by your attending physician in the case. Maybe get some lab results or see whatever was ordered when they came in. And then you'll have a chance to sit down and talk with your attending. And I think that this is sort of a classic conversation, right? The resident goes and sees the patient, does their exam, and then talks with their attending or maybe their chief or sort of whoever it is about what they think is going on. And that conversation isn't necessarily just straightforward. What do you think is going on? What are you going to do about it? Sometimes there's some extra teaching in here. And so we try and model that kind of interaction in DDX. And so, based on the information I skipped through pretty quickly, I think that this is likely to be a PE. How do we classify the severity of his PE? And so we can get some sort of discussion on this. Now, I'm a simple urologist, so I'm cheating a little bit here. Don't necessarily know all that much about PEs, but we can sort of talk about some of the scoring or guidelines or whatever it might be that kind of informs the decision making here, right? We don't just need to say, what are you doing? What are you doing? What are you doing? What's another quick diagnostic test we can perform now? This I know because everybody in the ED loves POCUS. And so you can see that as we work through this conversation, right, we're getting asked these questions that push the residents' thinking and aren't just a simple what next, what next. Like I said, residents do love multiple choice questions. They've essentially proven that they're good at them by this point. So we sprinkle a few in to make them feel comfortable. But we try and have most of these most of these cases rely on the attending interaction or sort of conversational interactions. Great, we've got some updated results. So great. Now what are we going to do for him? And again, I think sort of a typical conversation that you'd have with your attending. Again, urology is like, how do we get out of this as quickly as we can? So, you'd sort of go through this conversation and talk about what else you should do for him. And you have to think sort of across the spectrum here, right? What's the dispo? What's the medications? Let's put him on the monitor. Let's get him an observed bed, whatever it might be. We want the resident to kind of think the way they would in the hospital and not sort of the medical student answer of what's just like the right single treatment here, and then let's move on. So we'd go through this whole conversation, and at the end, the attending will ask us for the dispo if we haven't already showed it or shared it, and then we can talk about ICU admission. And then at the end of the case, there's a little bit of follow-up from the attending. Great, here's how the patient's doing now, and then some final teaching points. Again, all of this written by our faculty. to help convey what we think is the most important information about this particular case to residents. And then at the end, and then I'll skip over to a different case here just because our feedback isn't going to be very good. But at the end, the resident, like I said, gets a lot of sort of specific actionable feedback. And you as faculty can then go in and review that feedback. So this is now the faculty view, again, for a different case, but of how their whole cohort performed on this case. And so you can see for each of the steps of this case, how are my residents doing? And maybe where do I need to direct emphasis for these folks? We've tied these to the relevant competencies. And then you can also see sort of for specific details, how are they doing? Were they missing sort of key points in here? What were they struggling with? What were they doing well? Were they really nailing it? And then for a given learner, you can dive in and really see their feedback. And so this is the same feedback that they see at the end of the case, but you can review this yourself. And again, this can support that conversation where you start talking about where you're finding their issues and what's going on. So great, you're really good at coming up with an initial differential, but your histories are in trouble. Maybe you're taking too long, or you're just not associating your differential to the questions you're asking here, whatever it might be. And then when you get to management, you're doing an okay job, but there's some additional steps that you could consider, or you're consistently failing to think outside of the sort of direct treatment box or something like that. And then, of course, you can review, and there's only, I guess, 2 residents in this cohort, but you can review your whole cohort and see sort of who's struggling, who's doing well, where do I need a little bit more help. And again, I think this is all part of that early identification step. How can I figure out who needs the most help early so I can get them that support they need? So quick overview of DDX. Happy to answer any questions about it. And thanks again, Nikki, for taking us through the remediation stuff.
Thank you, Ben. And if any of you are interested in seeing firsthand how DDX can support your learners in your program, we invite you to sign up for a free trial. You can scan the QR code to get instant access. You can explore up to 6 cases in addition to trying our custom case generator. I'll also be sharing the link in a follow-up email over the next day or so. And then before we get into the Q&A, I just wanted to highlight an upcoming webinar on May 28th. The session will explore how medical educators can develop and practice coaching skills through an interactive AI-driven simulation experience. So during the session, participants will have the opportunity to engage directly with the simulation to experience how this approach can support coaching skill development. You'll hear from Dr. Alice Ting and Dr. Todd Cassis from Weill Cornell Medicine, along with Ben, as they share the approach and what they've learned during a recent pilot they've conducted. So if this is of interest, you can scan the QR code to register, and we'll send the recording if you're not able to attend live. I'll also be sharing the link to this in the follow-up email to today's session. And with that, we can get into questions. So if you have any questions, please feel free to ask in the Q&A box. Right now we have our first one. It says, great talk, like the systems approach to a complex set of challenges. I was curious if you are aware of situations that have arisen in coaching remediation that have challenged your systems to adapt. Can you share more about that and how you adjusted to the system?
Yeah, sure, of course. Nothing ever goes quite perfect, right? And you're always having to adapt, especially as we get to like a new generation of learners. And so 2 things kind of immediately come to mind. First was actually our feedback system that our program had in place when I first became program director. Just wasn't getting enough information to us. It was, in the ER, it can be tough because you might work with one attending and then 6 months later work with them. You're not working with the same person for a week. And so you can't just do like a weekly eval. And so we weren't getting enough information to know how our trainees were. So we completely revamped our feedback system and made it so that it is very, very short. All of us in EM have very short attention spans. And it is something we use MedHub at UNC. So we dove head first there and created very short feedback forms that only address 1 or 2 milestones at a time. And it's mostly just an open text box. And the goal is is that on the mobile app, they can just be like, hey, I worked with Joe today. He did da 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 great. He really struggled with these other things. And then, by the time I get to my car at the end of my shift, my feedback is done. And that feedback is immediately viewable by the trainee and by the entire education leadership team. So we were able to identify patterns a lot earlier. So completely revamping the feedback system was one of the major things that we did. Another thing that we did was adjusting some of the triggers for remediation. And so we did have a few trainees fail the boards in a couple of years in a row that were a little surprising to us, the folks who failed. And what we learned is that it really wasn't the trainees who were doing poorly at the bottom of these mock board exams. It was the ones who were kind of like just not making it into remediation. And so we actually added a kind of middle remediation section that we call the gray zone, where you're not in a full 100% forward plan, but we are gonna poke you and put you on a remediation light plan to make sure that you are studying, because those were the ones we found actually at the highest risk of failing the written boards later. Great question.
Great question. Okay, and I have one other question that just came in. How does the subscription work? Would I only get access to Help 10 residents, or would this be available to all of the residents? Approximately how long does it take to get through the case? And can you also show us how the feedback can be extrapolated to the milestones? So this one is for you, Ben.
Yeah, so you certainly can get access to for all of your residents, and that's sort of what we advise, especially again going back to that idea of early identification. It's hard to, actually to Nikki's point just now, right? It can be hard to know who's going to struggle without some way of proving that in advance. And board scores, as you all know, can be quite correlated with performance, but people can be really good at test taking and then not so good in the real world. And so we think this is a way to kind of do some of that identification and then ongoing tracking of sort of your whole cohort. So you can certainly get access to everyone. The cases are a little bit variable. The one I showed is probably about a 15-ish minute case. There are some communications cases where it's more focused on one single conversation that are a little bit shorter than that. But we know that residents are busy and don't want to do sort of hour-long experiences. So we try and keep these manageable for both the residents and for you. And then I can quickly show, let me share my screen again, how we sort of report out the ACGME competencies here. And so you mentioned the milestones, so we can certainly talk about what your goal is there and what you're trying to connect to. But this is how we map our rubric and sort of each of the steps of the sort of core steps of the case to those published competencies. So here's sort of each of the rubric steps. You can see where your cohort sort of falls into each of these buckets. Again, this is sort of sample data with only 2 residents in it, but you can see how they break out, and then how each of these is mapped to the published ACGME competencies.
We are just about at time, but we'll try to sneak in one more question, if that's okay. So, one competency that we have found challenging to remediate is on interpersonal and communication skills, particularly as it relates to communication with peers, patients, and faculty during stressful circumstances. What strategies do you recommend? I think this could be Nikki. I'll have you take a
Sure.
shot.
Yeah. I mean, there are a lot of the areas that are tough, and communication and professionalism are definitely the areas that are commonly areas on remediation that are tougher to solve. And it's highly variable what resources you might have at your institution or on your campus. Coaching is one that is very helpful, and one that AI is becoming a useful tool for. And so it doesn't have to always be faculty time, as I know in the next question was about time related to faculty helping with remediation, which is really tough. And all of this, it is tough. But using coaching, so if you have professional coaches on your team, or if you can use an AI version of a coach to help practice some of these scenarios, and recognize what is better behavior, better responses around communication. I sometimes have bought books for my trainees. I don't know if they read them or not, but some of them are readers. or listening to different podcasts that are out there that are much more related to the soft skills of medicine, I think are very helpful. And then role modeling. And so figuring out who they connect with, whether that's a chief resident or a peer or a faculty, so that they really feel like they have someone's best interests at heart, and the two of them can talk to each other about it, can potentially, like I said, shadow to see how they handle some of these scenarios. Sometimes it's just direct observation to see how someone else is, de-escalating, for example, a situation as opposed to escalating. But these are definitely tougher and much more ingrained habits in all of us as people. And so making sure you avoid anything about personality comments and make it about directly observed behaviors. And so when you respond with X, the other people in the room feel this or perceive this, are really important words to use, and bringing it back to how do you want to be perceived as a physician? Because most of these who are struggling don't want to be perceived as lazy or rude or mean or whatever other word you want to tag it to. And so tying it to what do you hope to be, and change those behaviors that are leading you a different direction, and how to get back to what is at your core.
Yeah, great point. Yeah, and DDX does have communication skills cases as well. So that is another way to use DDX for helping with remediation. So I know we're a bit over time. Thank you so much, Dr. Binz, for sharing your strategies and systems today with our audience. And of course, Dr. Ben Mueller, thank you for joining. And for everybody, take care and please keep an eye out for all future webinars.